Dr. Anurag Agarwal, Professor, Department of Medicine, Lok Hospital, and Dr. Mala Chabra, Consultant, Department of Microbiology, RML Hospital, and Dr. Sangeeta Sharma, Professor at Institute of Human Behavior and Allied Health Sciences, New Delhi. I welcome you all. Also welcome our chief guest, Dr. J.N. Srivastav, sir, for this session. I request you, sir, to address the participants and brief about the standard treatment guidelines lecture series. Over to you, sir.
Thank you, Annapurna. I hope I am audible.
Yes, sir. Yes, sir.
A very good afternoon to all of you. First and foremost, I want to pay my compliments to Dr. Sangeeta Sharma, who is a force behind this initiative, and goes a long way in building the state's capacities. The state capacity, I mean our doctors, our medical professionals, those who are working in the low resource setting districts, district hospital, in CHCs, PHCs, lower down. And this is the 6th series in partnership with Delhi Society for Promotion of Rational Use of Drug. In fact, I met Dr. Mala Chabla yesterday only, and Dr. Sangeeta Sharma. They are so passionate about the cause of promoting rational use of the drugs. So whatever the resources are available, they could be managed in a better way. We are extremely grateful to Professor Anurag Agarwal. I know as a clinician, as a medicine person, he will be extremely busy. Thank you very much, sir, for this larger good and for taking time out to tell the participants what are the things doable at their level in the states, in the districts. And the Mala Chavla had been the part of NCDC before, and she has, one of the flag bearers of this Rabies control initiative in the country. And that would go a long way. So participants are very keen to hear. But practically, let me share a personal experience that we notice, even like now I'm for immigrant to Delhi, staying for last 25 years, that the population of the stray dogs has increased, and incidences of the dog bite has also gone up during this COVID or the post-COVID period. You are the expert, you would know the reasons better. Maybe not getting the food, in whatever way been affected. My own neighborhood, I stay in Dwarka, notice many incidences taking place. We all know the country specific data. I will not go into those details. You are the subject matter expert. I understand that India contributes about 35 to 40% of the global burden of the deaths takes place globally on account of the rabies caused by the street or stray dogs. So our burden is huge. And we also notice that there is a sense of panic or the helplessness that when one gets bitten by the dog. And we are privileged that in Delhi we have got many institutions where the vaccine, even on 24/7, the person goes and will get some treatment. Not be the best as per the clinical protocol, but some treatment would be rendered to him or her. But the situation is extremely desperate. At times it becomes a political issue also. The rural setup in taluka or the tehsil headquarters, there may be a lone CHC or a small hospital, or so-called jhola chap or whatever one wants to call a doctor. But what does it do? At some level, that the importance of that immediate first aid I mean, I can recall, I'm sure that 3 experts would correct me if I'm wrong. The importance of washing, immediate wash, at least for 10 to 15 minutes. I mean, preferably in the running water with the soap cleaning. These used to be the cardinal principle which were taught to us. And practically, a lot of, in fact, not so scientific remedies looks. I mean, in the rural area, I come originally from a rural setup in state of Uttar Pradesh. I've observed, often and used to observe certain and unethical practices are also not so rational practices are also rampant. In that context, this series is very important, and in fact, we have under guidance of and leadership of Professor Sangeeta Sharma, we have been taking up the one contemporary topic. And once again, we are extremely grateful to all of you, Professor Agrawal and Dr. Chabla, and of course, sheet anchor Dr. Sangeeta Sharma. Without much ado, I request Madam and Sir Agrawal to kindly start the session. That is the plan. He has been engaged in, and he was supposed to come and talk to us. He is engaged with the health secretary in some other conversation pertaining to the G20, so he will not be able to connect, but he has conveyed his greetings and wishes and essence of, thankfulness to all of you for taking time out and talk to the public health professional and other professionals as well, working in the different fields. That would go a long way in strengthening the system and also improving the quality and patient safety, which in fact NHSRC and Anpurna, my colleague Arpita, who are around, they all are passionate about. Thank you very much.
Thank you, Dr. Srivastav, for providing us the support, and we needed that kind of, forum, creating a forum for connecting with, such a large group of people all over India. Otherwise, we wouldn't have been able to reach out to people from district hospital, CSC and PSCs. And I'm very much thankful to you for providing us that forum. And with this, today we will begin with this session's topic was dog bites, because this is something which everyone comes across, and we have two very eminent speakers here with us. Dr. Mala Chabra, she's currently working as consultant at RML Hospital. Now it is also called Atal Bihari Vajpayee Institute of Medical Sciences. She has over 36 years of experience, tremendous experience in zoonotic diseases. It's not only the dog bite that she expertise in, all the zoonotic diseases, and she has been very active academically also, working on this thyroid cross post-exposure vaccination for rabies and Louis Pasteur. Or she has so many of these accolades to her credit. With this, I invite Dr. Mala Chabra. I think Dr. Mala, you were having some problem with the PowerPoint. Even I couldn't open that from here. Try saving that and that file. Maybe there's something wrong with that file.
Okay. Can you hear me, ma'am?
Yeah, or maybe you'll have to. You also share with Annapurna. Do you have her this thing? I tried opening through Google Slides as well, but it's not opening.
Can I just try sending you once again?
Yeah, please do that.
Or should I start my part? Madam can continue because I have to leave.
Yeah.
Something like that we can do.
Maybe I think meanwhile while we are settling this thing, maybe
I'll start off,
Okay,
Yeah.
we go with Dr. Anurag Agarwal sir's session then.
Yeah.
Please like that.
So good afternoon, friends. I'm Dr. Anurag Agarwal, Professor Pediatrics at Maulana Azad Medical College. I was just rambling all alone long because Madam was trying to get a slide sorted. So I shall start my presentation and then shall talk about epidemiology, lab, and other related things. But I'll talk about second part of the session first, and I hope you all remain connected with me. So I'll discuss some case scenarios. I will discuss about immunoglobulins. I will discuss about vaccines, that is intradermal route, re-exposure prophylaxis, some videos on bone infiltration, WHO recommendations. And question and answers are always welcome. And I love getting stopped in between for question and answers, but this is a webinar. You can type in chat box. Maybe I'll try and answer, or Dr. Mala ma'am. She's a better expert than me, so she'll also answer later on. So rabies, it's a 100% lethal disease. We all know this. And there are around 15 now or 220 case reports of survival from rabies with severe neurological deficit. So as far as we are concerned, as clinician, it is a 100% fatal disease. Of course, a lot of studies are planned to try and manage this, use some antibodies and all those things, but intrathecally. But again, they're all experimental. So presently, it's 100% fatal. Once you had it, you have had it. Nothing can be done, and it's nearly 100% preventable. So we use the right prevention modalities. We can control this dreaded illness. Worldwide deaths around 61,000. India around 20,000. Madam will discuss in detail. As well, I was saying, this is 2004 data. The world has changed. Maybe we have around 5,000-6,000 deaths. So Madam will discuss this. I'll not touch on this. So now the question comes, which animals transmit rabies? So very commonly I get a call ki somebody was bitten by a mouse. Does he require anti-rabies vaccination? Answer is no. Another query I get a lot often was being bitten by a rabbit. So rabbit also does not transmit rabies. Other than that, I'm talking about animals which do not transmit. So mouse does not transmit, rabbit does not transmit. Bats in India do not transmit. Bats in the Western world, that is America, are the main source of rabies there. But in India, they do not transmit. Other than that, all wild animal bites, dogs, cats, monkeys, um, foxes, jackals, camels, mongoose, all these animals you will have to give a immunoglobulin and a vaccine, so which we'll discuss. So they will require post-exposure prophylaxis for prevention of rabies. Clear? So rabbits, no. Cats, no. Rabbits, bats, mouse, no. And the mouse I'm talking about is the one which bites in your household. If you're not very sure which mouse has bitten, is it one which is a large one? We call it goose in Hindi. So a big thing which looks like a mouse, but it is pretty big. If that is somebody who has bitten, it's better to take post-exposure prophylaxis. Now coming to squirrels. Squirrel bite, not very common. But yes, if it is an unprovoked squirrel bite, these squirrels are usually very shy animals. They don't come and bite you, but you are walking down, suddenly a squirrel comes and bites you. It's better to take post-exposure prophylaxis because around 15-20 dead squirrel samples were found to contain rabies virus. This data is from Sri Lanka and South India. Now squirrels we are giving, in the books it is written squirrels also is not required. That is the reason I have discussed this here. Right. So, what is the current policy of treatment? Current policy of treatment which we follow is wash the wound, disinfect, and vaccinate. This is what we are doing. Something is missing in this. This always does not work. Let me see. Okay. So this is a case report from Tejpur, Assam. Okay, good. So here, a 55-year-old female presented to the hospital with fever, headache, vomiting, and increased irritation. A clinic diagnosis of rabies was made. Somebody has asked, what about street cats? Yes, cats do transmit rabies. Cats, you have to give complete post-exposure prophylaxis. I just saw the question pop up on the screen. So patient was bitten by a street dog on the nasal bridge, and 2 weeks ago, 3 doses of vaccine was given. The patient developed rabies 2 days prior to 4th dose. What went wrong? The patient was not given rabies immunoglobulin. Another case report from Aurangabad. Same story. Child was bitten on right thigh, category 3 wound. Was given 4 doses of the vaccine. Immunoglobulin was not administered. Patient died before the 5th dose. Other case report from Bangalore. Same story. So this is a very common scenario. If you look at the data from IDH, around 1 year back, data was analyzed. There were around 49 odd cases. Out of them, around 10 to 15 cases had received the vaccine, had not received immunoglobulin and developed rabies. So the question which comes to our mind is, do vaccines fail? So even after giving vaccines, if somebody is developing rabies, what is wrong? Now, post-COVID era, we are we all have become a lot very sensitized regarding the way vaccines work. So the vaccines are antigens which are injected into the body, which lead to production of antibodies, and this starts around day 7 and reaches a good titer by day 14, and then it further rises. The first 5 to 7 days is the period, as you can see in this graph here. First 5 to 7 days is the period where there is no protection. So here the vaccine will not work because the vaccine is here this period the vaccine will not work because until this time the antibodies have not been made. So once day 7 crosses, yes, the vaccine will be effective. But if the virus binds to the nerve ending during these within first 5-7 days, nothing can be done against the virus. The virus will ascend slowly to the brain and the patient will develop rabies and die. So to provide the initial 5-7 days of protection, what you need is passive prophylaxis. Situation is especially when there are bites on the face, which are highly innervated areas very close to the brain. Multiple sites of exposure, so multiple bites here on various parts of the body, or bites on the finger, which is highly innervated, bites on the face. So these have short incubation period. Nerve endings are exposed. If you have a severe bite, so the child has bitten off so deeply that it has the dog has bitten so deeply that child has the nerve endings have been exposed, and the virus is directly deposited to the nerve ending. Here, because there is not much time and the virus binds immediately the nerve ending, you need something which is acting immediately, that is passive prophylaxis, is the immunoglobulin. So now coming to the category of exposure, we have category 1, 2 and 3. So let us not bother about category 1 and 2 because 1 hardly reports to us, 2 also very less. What we are bothered about is category 3. Simple way to remember because everybody has hundreds of things to do. Instead of remembering so many lines, any scratch or bite, even a drop of blood has oozed out or a drop of serum has oozed out from the wound, it is category 3. Very simple to remember. So any wound where a drop of blood is seen is category 3. If you are not very sure if it is category 3 or not, take a spirit swab, move it at the site where you have a suspicion of the animal bite. If a drop of serum has oozed from it, or if there is burning or tingling at the site, if you move the swab at that point, it implies that it is category 3. So a drop of serum oozing out, a drop of blood oozing out, or burning or tingling, if you move a spirit swab at that site, implies it is category 3 and this patient requires infiltration. This has to be kept in mind. Again, and more than 90% of patients reporting to our rabies clinic, animal bite clinic or anti-rabies clinic are category 3. Hardly any patient comes to us with a story of that he was licked and he is reporting to you. Most of them will have some kind of a bleed or something at the site. So now, what is the management which we have? Rabies immunoglobulin that has to be infiltrated into the wound. Of course, first wound washing, which is extremely important, followed by infiltration of immunoglobulin, and followed by completing the course of vaccination. So these are the 3 steps which have to be taken in category 3 bites. Now let us talk about rabies immunoglobulin. Rabies immunoglobulin is derived from two sources. One is animals, second is human. So animal sources is derived from equine horses. So it is known as e-rig, or derived from equine. So it is known as e-rig. So these are manufactured from the blood of horses. So what they do is that they have horse farms, cities like Hyderabad and Pune, wherein these horses are injected with rabies vaccines, a good quantity repeatedly. The horse will develop antibody against the virus, against the rabies virus. Then the blood of the horse is taken by putting a cannula or a catheter in his neck. Blood is drained out, and the blood is centrifuged. RBC is separated. RBCs are re-injected into the horse, and the serum which is separated is purified. From it, the specific antibodies are collected and packaged into vials and sent to us for use. So that is the way. There is a question regarding. Let me see if I am able to see the question. Or maybe we can take the questions later on. You can keep posting the questions. I'll take the questions later on, because they do flash on the screen, but I'm not able to. I was not able to read it fully. I just saw it flash on the screen. Let me see if I am able to get the question. Chalo, we'll take the questions in the end, but you can keep asking. If I am able to see the flash, I'll try and answer it there and then. You have the immunoglobulin, which was made from horses, and same way it is made from humans also. The human immunoglobulins are imported from China. We are not allowed to make it in India. So HRIG is sourced from China and ERIG from horses in horse farms. So these are the two major sources which have been used over last 40 years. There's another product which is available. I'll talk about it as we go down. Cat scratch needs rabies vaccination. Yes, cat scratch needs it. Are we to be given in case of horsebite? Definitely yes. You have to give it in case of horsebite. I agree with that. So we have two varieties of immunoglobulins, which I said was human. So the dose of human rabies immunoglobulin is 20 international units per kg body weight. The maximum dose, there is no upper limit. So if the person is 100 kgs, multiply 20 into 100, so it comes to 2000 international units. That is the upper limit. That is the maximum dose for that patient. Equine rabies immunoglobulin, the dose is 40 IU per kg. So 100 kg patient, 40 into 100, 4000 IU will be need to be administered to that patient. The upper limit of administration to him will be 4000 IU. ERIG is in India. ERIG we are giving after a test dose. WHO document says that testing sensitivity for equine immunoglobulin is not required, but we are doing it because the manufacturer's product insert is saying it that it has to be done. So, but WHO says it is not required. Why is it not required? The simple reason that the mechanism by which sensitivity comes positive and the mechanism by which patient will react after the immunoglobulin is administered are different. So even if sensitivity is negative, it does not mean that patient cannot have an anaphylactic reaction to the immunoglobulin. Having said that, I personally have used more than 2 lakh vials of immunoglobulin in this country. In my setting, I have used more than 2 lakh vials, and I have not needed to admit a single patient with any severe reaction. Mild reactions are, of course, there: fever, syncope, vasovagal, or some rash, some erythema. In fact, my previous medical superintendent got a bite, and was given equine immunoglobulin. He landed in the casualty because he had a bite. I was given equine immunoglobulin just 10 days ago. And on day 3, he developed redness around the bite side. And it was sore. I had to give him some antihistaminics, and it recovered within next 24 hours. So these are minor reactions, nothing to worry about. There are no severe reactions. How to do a sensitive testing? 0.1 ml of the immunoglobulin taken in the insulin syringe, make it 1 ml, and out of that, dilute it in normal saline, make it 1 ml, and out of that, you inject 0.1 ml on the intradermal injected intradermally over flexor aspect of forearm. That is the way to do it. You observe for wheal, erythema, induration, itching, tachycardia, fall in blood pressure, or fecal pulse. So this is the way you observe for sensitivity. Again, WHO says not needed, but we are doing it. Only needed for equine rabies immunoglobulin, not needed for HRIG, that is the human rabies immunoglobulin. So, some certain important points regarding this is that infiltrate as much as possible into the wounds. Number one, and remaining, if any, should not be given intramuscularly. I have made it bold red, not be given. So now you'll ask me that suppose the bite is say around 1 centimeter, how much can I infiltrate into it? Can I infiltrate 5 ml into it? Because as per the formula, the total dose which was coming is 5 ml. So earlier what we were doing was we were taking the immunoglobulin, infiltrating it to some extent, and remaining we were giving IM. So now the latest recommendation says that immunoglobulin should not be given IM because it is a waste. It does not lead to boost in antibody titers. And those immunoglobulins hardly reach the wound site where it is required. Right. So try and inject all rigs into all the wounds. So if you have a bite and there are say 4 puncture sites, so inject all 4 wounds. Do not leave any wound. So you have 4 wounds, inject all 4. If you leave one wound and the virus is there, it will bind to the nerve ending and cause rabies. So that is one of the reasons why patients, even after receiving rabies immunoglobulin, may develop rabies. In a situation when the wounds are large. For example, I got a call from Chandigarh, wherein a child was mauled by the stray dogs, and the child was severely bitten, and the volume of immunoglobulin required was so much that the dose formula, if we used it, it could not cover all the wounds. So the doctor was advised to dilute it in normal saline. So you can dilute even up to 10 to 15 times in normal saline. And but all the wounds have to be covered. Wounds should not be left. So presently available preparations are very safe. This I'll not discuss. This will be discussed by Adam. So now the issue comes is when you have a small wound, say 1 centimeter. The volume which you calculated from the formula of 40 IU per kg for equine, the patient is 50 kg. So 5 for the 22,000 IU. 1 ml has 300 IU in equine. So it comes to 6.5 ml. Now you cannot inject 6.5 ml into the 1 centimeter wound. So now what to do? So for this, we conducted a study. We decided, okay, let's have some kind of standardization wherein we will say that this is the amount you can infiltrate into the 1 centimeter wound. The remaining, you may not use it. You can use it for the next patient. Because we are saying that there is no role of IM administration of immunoglobulin. This was the study we conducted. We took around 100 patients and we calculated the immunoglobulin requirement in these patients by using wound-sized approach. So we found that the volume of RIG infiltrated into the wound per unit length was 0.75 ml per centimeter. It means that you will require 0.75 ml of immunoglobulin per centimeter. So if you have a linear wound which is 2 centimeters, you will approximately require 1.5 ml. If it is 3 centimeters, you'll require 0.25 ml immunoglobulin. Whereas if you follow the unit area method, unit area means if the wound has a length and a breadth. Wounds can be either linear or it can be having a dimension, that is length and breadth. So if you have a length and breadth, so the wound is say 1 centimeter long and 2 centimeter in breadth, then the formula was 3.18 ml per centimeter square. So 3.18 ml per centimeter square and 0.75 ml per centimeter. So linear wound, 0.5 ml per centimeter. Whereas if you have a length and breadth, suppose 2 centimeter long, 1 centimeter in breadth, 2 into 1, that is 2 centimeter squared. This person will require into 2, around 6 ml of immunoglobulins. You calculate the dose as per the body weight first, Then you calculate as per the size of the wound, and you give the amount which comes less at the site. If the amount requirement is coming higher, you dilute with normal saline. Simple as that, right? So this was the data which we published in Oxford Journal of Pediatrics. So this is the letter we sent the Director Family Welfare of Delhi to implement this guideline in Delhi also, because Delhi also we were infiltrating and giving IM. So we thought, let us remove the IM component, and we studied the requirement of average requirement of immunoglobulin. If we in dog bite patients, we found it was zero point 0.4 to zero point 0.5 ml only. If we calculated through the body weight, it was formula, it was coming to around 4 or 5 ml. So it was a net saving of a huge amount of money. So our cost was coming down to just 20% of the immunoglobulin cost, which is otherwise needed. So this will bring down the cost to 1/5. Now I am going to show you a video. This is the way wound infiltration is done. So please have a look. So this is a child being infiltrated. See the way, what we do is we move from out of the wound. We do not enter through the wound. We move from out of the wound and then go below the wound and inject. This is another video. And also you will see that you are outside the wound, you go below the wound and you infiltrate while withdrawing the needle. So you can, this is the 24 gauge needle. You can use a 26 gauge insulin syringe needle also for infiltration if the wounds are not very long. Look at the number of wounds in this patient. You will see 1, 2, 3, 4, and the video is moving. So a big wound here. So all these wounds need to be infiltrated, and no wound should be left out. I'm trying to rub it off, but so all the wounds need to be infiltrated, and the remaining immunoglobulin should not be given IM, right? So let's move ahead. So this is the last wound being infiltrated. So a lot of infiltrations are done, around 10 to 12 infiltrations are done daily at Lok Sabha Hospital. Other hospitals also infiltrate similar amounts. A child is being infiltrated on the face, just over the eyebrow. A girl infiltrated on the face here. Somebody being infiltrated in the neck region. So infiltration can be done anywhere. I got a question that there is a tight wound just below the nail bed. I know it is very difficult to infiltrate below the nail bed. So you can give just 0.1 ml or 0.2 ml at the local site, and which should be sufficient for that patient. Because see, the immunoglobulin it is highly concentrated. You wash the wound thoroughly, 90% of the virus is washed off. The virus has a lipophilic coat. So using soap and water, you can destroy the virus there itself. And the remaining amount can be covered by even 2 or 3 drops of immunoglobulin at the local wound site. So now, having talked about equine and human immunoglobulins, let us talk about the problems associated with these immunoglobulins. This was limited availability. Human immunoglobulin is imported from China, very costly. An adult patient like me will require around 40,000 rupees for infiltration. If I go by the weight formula, affordability, high cost, safety, potential risk of blood-borne pathogens. Yes, this is always theoretically there. Then there is always a risk of allergic reactions, the type 3 anaphylactic reactions, which we used to read pathology by equine serum. This is the equine serum they talked about. Skin sensitive testing was required. So to alleviate this, WHO said ki let us do something in 2002, and they approached various universities to do research on this topic and develop monoclonal antibodies. And those monoclonal antibodies, somebody has asked, do you dress the wounds? See, if the wound is small, you simply clean it, inject it, and leave it open. There's no need to dress. But if it is a large wound, the more pertinent question is, do you suture the wound? Just around 3 days ago, I got a WhatsApp from a super specialty, multi-specialty hospital that a child has been bitten, taken to that hospital, and the surgeons are insisting on doing fine suturing. I had to tell them that please don't do it. We do not require fine suturing in these patients because the more number of pricks you give, more chances of the virus penetrating into the wound. You simply give one or two stay sutures if you need to give it to keep the wound covered, and then do secondary repair after a week or 10 days. So let the wound heal, let the immunoglobulin take its effect, let the vaccine develop the antibodies, and then you do suturing. Dressing is not a problem as such, but suturing is a problem. Okay, so coming back to the topic, so WHO said that we should have some kind of monoclonal antibody, at least two antibodies, so that even if the virus mutates, uh, the second antibody will bind to the virus and destroy it. And these antibodies should be such that they are able to bind to the virus and are protective. So now, because of COVID, we all know what are antibodies which are not protective, what are antibodies which are protective. So here, the antibodies should be the ones which should bind to the virus and at least two sites, so that even if there is mutation, the virus is neutralized and the rabies virus is destroyed and patient does not develop rabies. So this started off. Then WHO decided that okay, CDC Atlanta USA and ADRI Ottawa Canada, these two were asked to develop antibodies, and two different countries, two different universities, labs were requested so that both of them supply the antibodies which are mixed, and there will be no issue of patents because it will be a different product, two antibodies from two different countries, different labs, and then this product was further researched and developed, and ultimately multiple trials were done and brought to the market, and now we have two products in the market which are monoclonal antibodies. So these are one is Twinrab, which is a cocktail of two monoclonal antibodies, Tocaravimab and Mirumavimab, that binds to site 2 and 3 of the G glycoprotein. The dose is 40 international units per kg body weight. So this is Twinrab, that is the brand name, cocktail of two antibodies, 40 IU per kg body weight. Skin sensitive testing is not required and is recommended for use by WHO. Another monoclonal antibody is also available from Serum Institute of India by the name of Rabies. This is also an excellent product, and uh, this is a single monoclonal antibody. Difference between Twinrab and Rabies is that Twinrab is of urine origin. So this is the way the product is produced. So if you if you remember a little bit of microbiology, how multiple myeloma cells were fused into hybridomas, made immortal, and then genes were introduced from urine source, and later they were spliced off, and then you had chimeric antibodies, then humanoid, and then human. And the lymphoma cells, multiple myeloma cells, I said, produced only human kind of antibodies. So the human one is Rabishield, and urine one is Twinrab. So these two products are there in the market. Both are equally good, both are effective, both are safe. Dosing is slightly different. Twinrab is 40 IU per kg, Rabishield is 3.33 IU per kg. So these two products can be used for filtration. So here is Rabishield and there is Twinrab. Two products available, and the dosage is 3.33 IU per kg for Rabishield and 40 IU per kg for Twinrab. So because these are artificially produced and there was standardized stock solution from which the antibodies can be produced rapidly, so we can have unlimited production, rapid upscaling of production. If somebody wants to know the spirit swap method, it's very simple. You have a site of bite and you're not sure it is category 2 or 3, a spirit swab, rub it at that site. If there is burning, that means the integrity of skin is breached and it is category 3. So coming back to Twinrab and Rabies Shield, these are two products beautifully made. One of them is made in India. Other one is made in somewhere else. Dr. Kanodia, sir, which one of the antibodies preparation is better? I do not want to go into that discussion, sir, but you have asked it. So both have their own advantages. Twinrab is basically a murine product, so there will be some development of auto antibodies. That means you cannot or you do not want to give second dose of Twinrab in case of second exposure. So first exposure you give Twinrab, complete your post-exposure prophylaxis. You cannot repeat Twinrab. But the advantage of Twinrab is that they are giving 600 international units of antibody per ml, whereas Rabies Shield is 40 IU per ml. So Twinrab is a much highly concentrated product. So maybe at the local site, you are delivering much more protein when you give Twinrab. As Rabies Shield, you are delivering less protein. Again, these are theoretical differences. Both are good products. You can use any as you want to. And if you look at these dosages, Twinrab is 3.33 IU. It is for Rabies Shield. Twinrab is 40 IU and Rabies Shield is 3.33 IU. So this simply means that at 33 IU, vaccine was suppressed. If you went to 5 IU, the vaccine was suppressed. So they came to 3.33 IU. Whereas with Twinrab, they went till 40 IU and after that, the vaccine was suppressed. So you are able to give much larger amounts of protein with Twinrab as compared to Rabies Shield. So one advantage for Rabies Shield and one advantage for Twinrab. So again, these are all theoretical. Practically speaking, both are good products. Use any, but use a immunoglobulin so that your patient does not develop these. So these are the various guidelines. This is the product. After completing post-exposure prophylaxis, what to do if again dog bite occurs? So we will discuss this as we go down the presentation. These are the vaccines available. I'll not read them, just a list. More brands can come and go. As far as we are concerned, all vaccines are the same. HDCV vaccine is no more available, and Viro and PCEC is available. They are same for us. Spirit will cause burning in category 2. No, category 2 skin integrity is intact. It will not cause burning. So this is the. Oh shit, my battery is running low. Just give me a moment. I'll put my laptop to charge. Just a moment, just a moment. Another of the problems of webinars, battery can go low. So modern rabies vaccine, okay, I've shown you this. Let's move ahead quickly. So two routes of administration, intradermal and IM. I think I have exhausted my time. I'll move quickly. Intradermal, there are 4 doses, 0, 3, 7 and 28. Whereas IM, there are 5 doses. This is what we are following in India. 0, 3, 7, 14 and 28. WHO says 4 doses are sufficient. In India, we are following the 5-dose schedule. So let us stick with that so that if the medical legally to be safe, we are giving 5 doses. Although having said that, 4 doses are also sufficient. Even 3 doses are sufficient. But most importantly, we have to give immunoglobulin and then the vaccine. So now somebody had asked, suppose you have had a previous dog bite. What to do? If you have a previous dog bite and you have taken a complete post-exposure prophylaxis, then you are prepared for 3 months. So till 3 months, you can have multiple bites. You do not require any vaccine or immunoglobulin. And after 3 months, you require only 2 doses of the vaccine. That is day 0 and day 3, and there is no need of wound infiltration. That is the reason we are saying that please complete your schedule of post-exposure prophylaxis. And once you complete it, you are immunized for life. And in case of bite, after 3 months, you just require 2 doses, day 0 and day 3, and nothing else is required. Immunoglobulin is not required. So this is that. Intradermal regimen, again, as I had discussed, it is cost effective, a viable alternative. We are using it across Delhi in all the government setups now. And vial is kept at 2 to 8 degrees, can be used till 6 hours. Sir has asked Dr. Kanodia that for how many years 2 doses are sufficient. Sir, this is lifelong. We have 25 years study which is showing that the efficacy is maintained. So it is for life as such. Intradermal, if you are using it, it's an excellent route. Cost is 1/5. Efficacy is same. And nowadays we are giving FIPV, that is fractionated IPV, the same on the same premise. So excellent route, and the regime is 22202. So day 14, we are not giving any dose. And now we have a new regimen. Again, we are not using it in India till now because not approved by our national guidelines, which is thus 3 doses, 037 here. So I have just mentioned it, but we are still not using it. Once Government of India approves it, we shall start using it. This is the IPC regimen, Institute Pasteur de Cambodge. So ID administration, important, a bleb should be raised. Look at the beautiful bleb raised here, around 3 to 4 mm. That means you have given the vaccine correctly. And now coming to pre-exposure prophylaxis. Pre-exposure prophylaxis is just 3 doses, which we are using. Day 0, day 7, and day 28. This pre-exposure prophylaxis, either you give 0.5 or 1 ml IM. Kanodia sir, no need of repeat antibodies once you have taken complete post-exposure prophylaxis. After taking, the third dog bite occurs after second time vaccination. This is a topic of debate. I can go on this, but Madam Mala is waiting and a lot of panelists are waiting. After taking 3 doses, day 0, day 7, day 28, that is pre-exposure prophylaxis. You take 5 doses post-exposure prophylaxis. Titers in around 90% patients are maintained till 1 year, around 80% till 5 years, and even 70 to 60 to 70% till 10 years. And we are not bothered about the titers, but we are interested in the formation of memory cells. So memory cells will form after 3 or 4 dosages. So anytime later in life, even if a single dose of vaccine is given, your titer will boost up. So now third bite, fourth bite, fifth bite, do you need to give 0.3? Ideal way would be you go and get your titers done. If your titers are low, you go and take the boosters. But the test is very costly and available only in 2 centers across the country. So it is not feasible. So what we say is, yes, you go and take the vaccine, being on the safer side. Multiple doses will do you no harm. You will have lots of antibodies, nothing more than that. So this is more of a theoretical question. Yes, problem, but well, that is the logical answer to it. So sixth dose at day 90 is no more given. That has been done and dusted because titers are found to persist for long. And see, we are interested in protection during the first 1 month. That is the time when the virus can bind to the nerve ending. If it is not bound in first 1 month, there is hardly any chance to bind later. So 0, 7, 28. And in case of in case of exposure, what you do is day 0 and day 3, as we discussed. So I think I'll rise here, and Dr. Mala will take over from here. What if antibodies taken only on 0, 7, and 28? I didn't get the question. Please repeat your question. So most cases reporting to our OPD are category 3. That is any bite or scratch with break in skin integrity. Simply means that you take a spirit swab, move it on the wound. If there is burning, it is category 3. Please give immunoglobulin. And only local immunoglobulin is required. Do not give IM immunoglobulin. The cost will come down rapidly. The pain will decrease. The reactions will decrease. Patient will be happier. And again, use any RIG, but use RIG. So use any rabies immunoglobulin, whatever is available to you. Use equine, use human, use monoclonal, use twinrab, use Rabies shield. All are good, but use some immunoglobulin. Monoclonals are the future because humans are very costly and difficult to procure, not easily available. Equine made from animals, lot of cruelty. I feel it is cruelty the animals, but cheaper source. Now we have the beautiful monoclonal antibodies, which are can be mass produced, production can be ramped up easily, unlimited supply. So they are the future. They shall be available in unlimited quantities. There is no role of IM administration of rabies immunoglobulin. Awareness is the key to prevention of rabies death. So please be aware. Ask the school. Ask your kids in school. Report any dog bite. Do not be afraid of reporting dog bites. Report to the health worker. Take immunoglobulin. Take vaccines. The best is take pre-exposure prophylaxis. I have not devoted much time to pre-exposure prophylaxis, but we are trying to get it pushed into the Government of India program as such of immunization, so that we are able to have pre-exposure prophylaxis in the program itself. So Umesh Bharti sir is there. I did not know. So a lot of questions are there, ma'am. I think I'll end here. And this is the WHO schedule. I'll not discuss this. Dr. Madam is waiting. So this is my poster which I display outside the rabies clinic. Simple messages: wash the wound, do not apply mirchi and all that. Emergency tray, which should always be ready in case of whenever you are running any wound with injections.
Dr. Anurag, can you go back to your previous slide?
This emergency tray, ma'am.
No, the education material.
Yeah,
I
yeah,
think
yeah, yeah.
go through this one. This is also equally important.
Okay, so simple message on the slide. कुत्ते व अन्य जानवरों के काटने से रेबीज हो सकता है. जानवर के काटने पे क्या करें? घाव को साबुन व पानी से 15 मिनट तक धोएं. घाव में ARS का टीका जरूर लगवाएं. दैट इज द इम्यूनोग्लोबुलिन. नियमित तौर पे वैक्सीन के टीके लगवाएं. वी ऑल नो द वी हैव टू फॉलो द शेड्यूल. So please follow the schedule. घाव को खुला रखें. That is, leave the wound open. घाव पर मिर्ची चूना आदि ना लगाएं. Do not apply chilies or all kind of spices to the wound. रेबीज एक जानलेवा रोग है. So rabies is a life threatening illness. तुरंत अपने डॉक्टर से संपर्क करें. Meet your doctor immediately and save lives. So this is the poster, ma'am.
There was a question. People are still confused between category 1 and 2.
So I did not go into 1 and 2 for the simple reason that they are least of our concerns. What we are interested in is
from a
category
medical
3.
point of view, yes.
I will take it, ma'am. I will
Okay.
take it.
Madam,
fine.
chalo,
Doing
Dr.
the
Mala is there.
categories.
She will explain it. So what we are more interested in is the patients who report to the OPDs. They are usually category 3. Hardly any 2 report to us. So what has happened is that when we try to remember 1, 2, and 3, now we forget the important message that any drop of blood or serum from the wound is category 3 and needs to be infiltrated. Rest, Madam Mala will discuss. This is the emergency tray. This is the wound washing area which we made in our hospital. Simple wash basin here. Red soap here. So if you have a wound on your hand, you can wash it here. If you have a wound on your foot, you cannot put your leg here. So we had this toilet jet. You can simply sit here and wash like this man is washing. So a girl is washing her wound. These are pictures which were taken when the procedure was going on. Nothing which was specially created. This is wound being infiltrated by my nursing staff. So nursing staffs are much more efficient than us in doing this. They do it day in and day out. Is infiltrating the face also. A bleb is being raised. Beautiful bleb by one of the same nursing staff. In fact, you can see the bangles here. She is the same lady. A beautiful bleb being raised. Child showing off his bleb. Hey, look, I have a great bleb. And let's end rabies together. Rabies 0 by 2030. So we are planning to end tuberculosis by 2025. WHO says 2030 and rabies by 2030. Let's hope we achieve that target. So a lot of queries. I'll answer a few. Dr. Mala will answer most of them. And this is our website, consortiumagainstrabies.com, and email. You can always mail us your queries. We'll answer them in 48 hours. consortiumagainstrabies@gmail.com, a NGO which we like-minded government doctors made. We work in the field of rabies. Now, a lot of people want the PPT. I can always share the PPT. If, Madam can use it. There is no problem with that. You can
Please
always
send it to me. I'll forward.
you can acknowledge consortium and use the PPT. I have no problem. Main aim is to spread the message, nothing more than that.
Thank
And
you. Thank you, Dr. Anurag. Yes.
Lots of questions are there.
I think during your presentation itself, you have answered most of them. There are 1 or 2 left. I think Dr. Mala will be covering those those also will be covered during presentation. We also have Dr. Arvind Mohan with us today. So if anything is left, we can have this. Dr. Umesh
Yeah, yeah,
Bharti
yeah,
is
yeah.
also there.
Umesh Bharti sir is there, Dr. Mala is there, so they'll answer all the questions. I think I'll take your leave because I have to catch a
Yeah,
flight.
yeah. Please,
And
thank you.
I'm
Thank
looking
you
for
for.
the option. Yeah, I think here it is. So I'll stop sharing. Where is the window? Share. How do I?
Stop share. Stop share. Huh.
Where is it? Share, assign, mute, stop video, participant, annotate, chat,
नो नो नो, आप अपने वाले वो जो वो वाला है ना, उस पे जाइए।
share content.
वेबएक्स, ये
अच्छा,
वेबएक्स वाले पे उसमें आएगा।
वेबएक्स वाला कहाँ गया? एक्चुअली हम लोग है ना, लेट मी सी, ये है क्या?
हाँ,
नहीं,
वेबएक्स वाले पेज पे आएगा स्क्रीन पे। ये
साइन
ये
म्यूट
पावर
कहाँ गया?
पॉइंट वाला है।
अभी क्या
स्टॉप
आपको मेरा स्क्रीन दिख रहा है?
है
आपको मेरा
लास्ट।
स्क्रीन
हाँ, आपका थैंक्स वाला स्लाइड है ना अभी।
आपको
वो
अपना
चल रहा है?
पावर पॉइंट
लेट मी सी, स्टॉप शेयरिंग दिख गया मुझे। गुड,
हाँ, ठीक है। थैंक यू
चलो
डॉक्टर
ग्रेट
अनुराग,
ग्रेट। हाँ,
स्पेयरिंग टाइम फॉर अस। आई थिंक थोड़ा सा हम लेट चल रहे हैं, बट इट्स ओके। नाउ वी मूव ऑन टू डॉक्टर माला छाबड़ा's presentation. I'll be showing from here. I think you can see my screen.
Yes,
yeah.
ma'am.
So okay, I'll just take your leave. Thank you so much. Bye.
Thank you.
Bye.
Thank you. Ma'am, please carry on.
So, Namaskar, and at the outset, I like to thank NHRC and DSPRUD for giving me this opportunity, the subject which is very close to my heart. And ma'am, next slide. Can we go to the next slide, please? Yeah. So I've been working, as I've told, for about 24, 25 years on this subject. And a lot of questions will be there. Dr. Anurag has covered quite a few, so it made my job very easy. But still, there is so much. Let's understand why we are doing what we are doing. Why are we giving vaccines? Why are we giving immunoglobulins? And why are we not able to control this disease when the disease is as old as our civilization? When we see these oriental pictures, we know that even the caveman knew about something wrong with the dog, and that you don't have to go near such a dog when it's depicting such a behavior of elevating fear to man. Otherwise animals will be fearful of man, but they come close to you, they bite you unprovoked. This was known since the mankind existed, but we are not able to control it. Next slide, please. So, and this is the problem worldwide. And however, some countries have controlled it. They have had a strategy to control it. But our country, we still the disease. Next slide, ma'am. The disease continues to be endemic in India, and globally there are 59,000 deaths, and India contributes to 35% of global deaths and 60% of Asia deaths. So this is the estimated government figure. However, from last few years, we are running a national rabies control program and promoting very effective animal bite management. And I have been to, I think, almost all the states for giving talks on animal bite management. Even at Pont Khurd, where Dr. Anurag Agrawal was there when they wanted to start intradermal. So I think the deaths must have come down, but we are in the process of evaluating this as to what is the effect of effective animal bite management that we've been saying. So in our country, the disease is prevalent throughout our country. It is endemic throughout the country. So that makes our life easier because the guidelines have to be followed throughout the country, except for waterlogged islands of Andaman, Nicobar and Lakshadweep. And let it be very clear that even these places, because of their geographical location, because they are waterlogged, Andaman, the virus has not reached there. If the virus reaches there, then there is nothing that can stop from rabies to occurring there. So let's protect these islands. And Lakshadweep, are you aware that there are no dogs in Lakshadweep? There are no dogs in Lakshadweep, but there is only one police dog. But again, There are so many other wildlife, so many other animals. So if the virus reaches there, it will be there. Throughout the world, we have to stand united against rabies, as Dr. Anurag last slide said, 0 by 2030. That means dog-mediated rabies can be controlled and it should be stopped. And I was saying why we have not been able to control rabies, because it is One Health approach that we have to follow. It is not only that only human sector should work. Now that is none of the clinicians' problem, but for public health people it becomes a problem, because it has to be a coordinated approach between the veterinary sector, between the wildlife sector, between the animal sector, between the health sector. Health sector, our responsibility that we manage animal bite cases appropriately. Veterinary sector should be able to take care of dogs by vaccinating them. And vaccination is the basic strategy in animals to prevent rabies. And now all the multi-stakeholders globally are strategically working together to achieve this target of rabies 2030. Next slide, please. So we did a study, we wanted to know as to where should we emphasize. And we did this study, a multi-centric study, while I was at NCDC, to know what is the knowledge, belief, and practices in general community. I will just take one question that we asked the general community, the doctors treating animal bites and doctors not working in anti-rabies center, and see the response. So this is for general community. You see, when we ask them whether these animals, all the animals that are listed, cat, cow, monkey, wolf, mongoose, rat, rabbit, lizard, hen, snake, if a person is bitten by these animals, should these people be treated? And you see, about in general community, about 30 to 40% people had the knowledge of these should be treated. They said all these should be treated, and some people said no. But maximum people, 50% of the general community, did not know what to do. So they said we don't know, which is very good, because if they don't know, they will look for answers to it. Now this was general community for this question. Let's see what happens. What is the best way to this is again general community. Best local treatment, only 30% said that wound should be washed with soap and water. 20% thought that antiseptic dressings are best, and application of indigenous products. Indigenous products means, when we did this multicentric study, I went around the country, did it in 7 cities across the. So in some places, like in Delhi, they would apply oil and chilies on the wound. You go down to Maharashtra, they apply chuna. You go down bit down Gujarat, they were burning the wounds with iron, thinking that that will improve. You go down in Northeast, they will apply tea leaves, they'll apply coffee. Entire kitchen goes down to the wound except for soap and water. So this was our problem. Next slide, please. Next slide. So coming to doctors working in anti-rabies clinic, now when we asked them whether cat, cow, monkey, wolf, mongoose, and jackal needed treatment, see, 50 to 80% doctors said yes. And there was significant number, 20 to 40% of doctors said no. And none of them said, I don't know. Which means that they will be sure of their answers, but they will not seek answers. Whereas cat, cow, monkey, wolf, mongoose, jackal, the animals listed here as told by Dr. Agarwal, all of them need to be given post-exposure prophylaxis. Next, please. And these animals, rat, rabbit, lizard, squirrel, hen, snake, may not need treatment, but our 30% of doctors are giving treatment and 60% are not giving treatment, when really they do not need treatment. And there is shortage of immunoglobulins, as already talked about. These animals do not need treatment. So what is the conclusion? That these kind of seminars and revision on these seminars becomes very important for doctors to understand who to treat and who not to treat. Next, please. Next slide. We did another study of rabies in Delhi, and we sort of saw 241 rabies cases, true developed rabies cases. And wound care was not given in 99%. Anti-rabies serum was not given to 99%. Anti-rabies vaccine was not given to 91%. we clearly, concluded that if appropriate animal bite management, all these cases died because they did not get appropriate animal bite management. So, by and large, appropriate animal bite management will prevent development of rabies. Now, rabies, I always say, is nearly 100% fatal and is nearly 10% preventable. How is it to be prevented? By appropriate animal bite management, which has already been discussed. Now, this slide has also been discussed, but I see some questions in the chat, so I'll emphasize those. Dogs, cats are most common animals, domestic animals. So, bitten by these, it definitely has to be treated. All the peridomestic animals, whether you're bitten by cows, buffaloes, sheep, goats, pigs, donkeys, horses, camels, all these have to be treated if a person is bitten by these. All wild animals, all the bites in jungle, be it by squirrel or by rats or by any animal, they have to be treated as category 3 bite, which means if a person is bitten in a jungle, whether it is a scratch or a bite or licking on abraded skin, all those have to be treated as category 3, which means a person should be receiving vaccines as well as immunoglobulins along with the wound management. I will talk a bit on wound management also a little later. Now, the previous slide, ma'am. Now, coming to bat rabies, this has not been reported in India, but vampire bats, rabies has been reported in American, South America, and many other countries. We do not have those bats, but we get so many times people who go in caves, people who go in jungles, they ask us, should we take any precautions? So in these cases, we do advocate giving them pre-exposure prophylaxis, because we don't know what kind of bats are there. As of now, the vampire bats, which can transmit this disease, have not been reported from our country. Rodents, that is rats, Dr. Agarwal clearly said that no need. We tested about 5,000 rat brain collected from domestic and peridomestic regions near the jungles, also from the jungle, and none of these were positive for rabies antigen, which means that we should not be treating rodent bites. Having said that, if the bite, as I qualified, occurs in jungle, then it should, whether it is a bite or a scratch, it should be taken as category 3 bite, and wound management, immunoglobulins and vaccines have to be given. Now, what about bird bites? I always get questions, especially people go to Haridwar and Rishikesh, there is a geese and duck pond, try and feed it, and that time the serrated beak causes injury what would you do then? There is so much of greenery in Delhi and people were standing outside under the tree, vulture came in and scratched the head because there was something on the head to be eaten. So what do you do in such cases? Now, should those bite be treated? Those scratches should be treated. Now, birds, rabies is disease of mammals. Birds have a higher body temperature. That is why the virus will not survive, multiply, and will be excreted from in the saliva. So these bites need not be treated. So this is how the science goes that bird bite should not be treated. Next slide, please, ma'am. Now, coming to, there's a usual question of observation of animals. Should we observe the cat and dog or any other animal? Now, this is the cattle bite. Now, when we talk about fields, when people have cattle at home, they will feed the cattle and things like that. So there will be a question. Or if you go to northern part of the country, they have sheep and goats and they feed them. Sometimes, they're playing with them and they get bitten. So can these animals be observed for 10 days, which we say classically is written in the books, observation animals for 10 days. Now, let's remember that this observation is only for dogs and cats and no other animal. And even for dogs and cats, if your one is exposed, start treatment immediately and then observe the animal. You should not wait कि ठीक है 10 दिन we'll watch the dog or cat and then we will start the treatment if the animal gets sick. That's not the routine. So you have to start the treatment immediately and then continue observing the animal and modify PEP. Now, what is modification of PPE? Usually, when we are doing the intramuscular schedule, we do 5 doses. Now, watch my hand, please. This is 0, 3, 7, 14, and 28. 5 doses on 0, 3, 14, 17, and 28 days. Now, how do you modify BP? You have given 0 day, given 3rd day, given 7th day. And next dose is on 14th day. If animal is alive, forget the 14th day dose and give on 28th day. Why are we doing this? Because you are converting your post-exposure treatment to pre-exposure prophylaxis. What is pre-exposure prophylaxis? 0, 7, and 28. So with one extra dose on day 3, you have converted your post-exposure treatment to pre-exposure prophylaxis. What is the idea of converting post-exposure to pre-exposure? Dog is healthy. So after 10 days, but you're still doing it. Why? Because if you get bitten again, if you have re-exposure, you would need only 2 doses without immunoglobulins. So that is the importance. So carry home message from this slide is that observation period is only for dogs and cats, not for any other animal. Why do I say that? I say that because the incubation period of rabies is variable in animals. So pathogenesis in dogs and cats is defined. And we know that if the animal is suffering from rabies, it will die, dog or cat will die within 10 days. That is why, within 7 days actually. That is why maximum period of observation is, but for other animals, we cannot say that they will die in 10 days. It may be prolonged. So, animal bite, I always say, is an urgency. And it may not be an emergency. So, what is the difference between the two? Emergency is that one has a heart attack, immediately rush to hospital. Urgency is that wash the wound with soap and water and take treatment as soon as possible. Suppose you're bitten at 2 o'clock at night, you may not wash at least soap and water washing is available to you. Do that and you can wait for a few hours to go to the hospital to get immunoglobulins and vaccination if it was a category 3 bite. But you have to treat it as urgency. Now, what is the vaccination? Another question that repeatedly is asked to us: what is the role of vaccination status of biting animal? Now, some of us have pets at home, and we get them vaccinated, or some of us take the responsibility of street dogs, and some NGOs come and vaccinate the animals, especially on street stray dogs, and they say that this animal is vaccinated. Would you believe it? Would you trust it? Now, it is a fact that animals vaccinated against rabies do not suffer and transmit the disease. But what is vaccinated? At least 3 doses of vaccines. So for your pets, you would know whether you are given 3 or 4 doses, right? But vaccine failures have been reported in animals. Why? Improper administration of vaccination or inadequate doses. Only one vaccine dose has been given and the dog has been labeled to have been vaccinated, or we are not sure of the quality of vaccines as against the human vaccines. Human vaccines are very good vaccines, but dog vaccines, sometimes poor quality vaccines come. Some of the vaccines are very good, excellent, but sometimes, poor quality of vaccines do come in the market. And then the health status of the dog. What is the immune status of the dog? You've given 4 doses of vaccines, but is the dog healthy enough, especially the street dog? So lab documentation of immunization, which means anti-rabies antibody titer, should have been done. So if that is available, if anti-rabies antibody titer is available, we consider that dog vaccinated and no need for animal bite management. But that is usually not done. So irrespective of the vaccination status, other than your pet dogs where you know that you have given 5 or 6 or 7 doses of vaccine, post-exposure prophylaxis should be given to the person if he or she is bitten by an animal, by a dog or a cat. Next. So what is the mode of transmission? This we know. We've discussed animal bites, of course. Now, can licks transmit rabies? Anybody, can you think of whether licks can transmit licks on abraded skin or mucosa? Now, before I answer that question, I want to say that skin is a beautiful organ that has been given by nature to us. And intact skin prevents many organisms to enter the human body. So it is kind of a kavach. It is kind of a protection to us. So on intact skin, if there were licks, then there is no need for anything. Just wash it with soap and water. Now, if their skin is abraded skin, can the infection can be rabies virus can get transmitted through abraded skin. Whereas mucosa, even intact mucosa, the rabies virus can be transmitted. Now, this basically what we have to understand is how do the virus gets transmitted. For that, we need three things. One is abrasion in the skin, which means there should be something that has abraded the skin. It can be teeth, it can be nails, and second is saliva and the virus. So load of the virus. So if that happens, licks on abraded skin, can transmit, because now you say where is the virus on the if the person has just the animal has just scratched, then animals have tendency to lick their paws, so they can deposit virus in saliva. So when they scratch, then the virus can be transmitted. Abraded skin, virus can be intact mucosa, virus is transmitted. Why I'm telling you this is that I'll give you an example. We get so many patients like this and so many questions. So there was this person who developed, who was brought in the casualty with breathlessness, shortness of breath, and immediately when the anesthetist was called, as the anesthetist saw the patient, he saw the patient gasping, immediately intubated it. So while intubating, he coughed and there was some secretions which the anesthetist felt probably went into the eyes. Later, this case was diagnosed as that of hydrophobia or aerophobia, which is a classical symptom of rabies. So they thought the person is gasping while he was when he was depicting the features of hydrophobia and aerophobia. Now, the anesthetist was so upset because he had got some saliva fallen into his mucous membrane. So this can happen. What I want to emphasize here is that sometimes the classical symptoms, here they were classical symptoms that couldn't be recognized. Follow standard precautions while seeing your patients. So you wear your masks, and if you're touching body fluids and secretion, wear your gloves and try and cover your eyes. Now, this anesthetist was given post-exposure prophylaxis, but how to give immunoglobulins? So you can instill immunoglobulins in the eyes by drops, but that may not have the answers, that may not answer the question. So it is better to protect in these cases. Now, unusual mode of transmissions are aerosol transmission. Aerosol transmission usually will occur in the lab when we are centrifuging a lot of virus. The virus can be transplanted. Organ transplantation, can it go? Now, there is a whole case series report. Corneal transplantation, all of us have heard about 22 case series have been reported by corneal transplantation. But I'll give you an example. In US, there was a case of encephalitis and was going to die. He pledged his organs. He donated his organs, and his organs, a liver, part of spleen, right iliac artery, and cornea was transplanted to 4 different patients, and all 4 of them died. Later, they realized that they died of rabies. And when they went to the donor was suffering from paralytic form of rabies, which is encephalitis. So now the organ transplantation has become that, it's such an expensive procedure. And if you don't take care of such things, then the entire procedure is slashed down. Now, ingestion, can it transmit the virus? This I'm asking you and I'm telling you is because there will be questions that if a person has taken milk of a rabid cow, can the virus be transmitted? So here, again, now there is a lot of documentation. Now this again happened in the developed world, where they pool the milk and they then distribute it through their system, pasteurize it and distribute it. But in our country, even raw milk has not been found to transmit the disease. Why? And again, there is so much of protection in saliva and the stomach, the acidic pH. So we do not say that the milk of a rabid cow can transmit. However, having said that, it is always better to boil the milk and drink. Even pasteurization can kill the virus. This virus is very labile. So as soon as the temperature reaches 60 degrees, the virus gets killed. Now, sexual transmission, again, there will be exchange of excretions or secretions, so it can transmit the disease. Next slide, please. Coming to the structure of virus, this I'm not teaching microbiology, but I'll give some carry home messages on this slide. So it is a killer bullet, we know, and the green things that you see on the virus are called the glycoprotein spikes. Now, why I'm saying this is that this entire virus is this forms the envelope of the virus. Now, this envelope has the lipid content also. And what is the reason I'm telling you this is that this can be inactivated by or dissolved by the soap. What is the importance of washing the virus with soap and water? As soon as you apply soap, now there will be a question, ma'am, Dove se dhole, ma'am, Lakh se dhole, ma'am, isse. So it has to be a detergent. It should have the soap, not the cream. So Lux, Lifebuoy, all those work, but cream-based soaps may not work. So you have to wash with the soap and water, or kapde dhone wala sabun, the detergent. You wash it with soap and water. Then you're dissolving this envelope. Once this envelope is dissolved, the virus gets inactivated. Right? So that is the importance of this slide. Second carry home message again of this slide is that there's a glycoprotein. So when we give vaccines, the antibodies are generated against these proteins. So they have the lock and key mechanism and they neutralize the virus. Right? So carry home message from this slide is wash the wound with soap and water because you are going to inactivate the virus. And when we give vaccines, the virus gets inactivated by the same principle that the lipid envelope is dissolved. Next slide, please. Now, this is again a very interesting slide. I'm not going to teach pathogenesis, but I'm going to give you carry home messages at each step. Now here, if you see, I don't have the pointer. If you see the dog is biting the human being. Now, when he's biting, as I've already said, there will be abrasion in the skin and the saliva and the virus is getting deposited there. So we have made, the dog has made sure that the virus is, if it was rabid, the virus is going into the skin, right? It's going into the system. Now, first there is local multiplication of the virus there. And then after that local multiplication, the virus gets into the nerve endings. And once it gets into the nerve endings, then it no stopping there. Now, for how long the virus is going to be sitting there and multiplying or going to be just silently sitting there, we do not know. I spoke about incubation period. This is the reason for variable incubation period. As to if virus is just going to sit there or multiply and rapidly going to get into the nervous system. As soon as it gets in nervous system, it is out of our control. Now, what is the carry home message here? That virus is deposited there. That is the importance of washing with soap and water, that you are decreasing the virus load as much as possible by washing them with soap and water. And that is the reason that you infiltrate immunoglobulins there. Why in what are immunoglobulins? They are ready-made antibodies. Now, our body is also making antibodies when we give vaccination. So, the time of generation of antibodies by giving vaccination is covered. It takes 7 days. So that time is covered by giving passive immunization, that is immunoglobulins or monoclonal antibodies. When you give monoclonal antibodies in that local site, it neutralizes the virus. If anything is remaining, after washing the wound with soap and water. Now, that is also the reason that we infiltrate all the wounds, because virus could be anywhere. That is also the reason why we give virus around the wound and in depth of the wound, so that all the virus gets neutralized. So, and now next question will come is that suppose a patient comes after 10 days to you or about 20 days, what will you do? Will you manage that case or not? Ma'am, can I have the previous slide, please? Will you manage that case or not? Now the answer lies here. we do not know for how long the virus is going to sit quietly. That is why giving benefit of doubt to the patient, even if the patient comes after 10 days or 12 days or 15 days, or we treat it as a fresh case and give immunoglobulins as well as vaccination. Now, once the virus travels the nerves, it is out of our control. Then it goes to the brain via the spinal cord. It goes to the brain, and then it comes down to the saliva, right? So from saliva, the cycle starts again. So same thing happens in dogs, same thing happens in human beings. So dogs will bite another animal or a human being, the virus gets transmitted. Humans usually will not bite. So the humans are dead end of the host. Now here, two things again. One is that immunoglobulin should be infiltrated locally, intramuscular. There's no point giving, because at no point there is viremia occurring. Virus does not enter the blood at all. So that is why also the blood is not a good specimen to subject it to lab. And we need only brain tissue or nervous tissue if we have to test for rabies virus, right? So these are the carry home messages here, that wash with soap and water, give rabies immunoglobulins locally, no point giving in intramuscular region, and viremia never occurs. So no point sending blood sample to lab. It is the nervous tissue which is going to help. And from the nervous tissue, the virus goes to different organs. That is why organ transplantation should be very carefully done from the case of encephalitis. Nowadays, they don't take cases of encephalitis for virus transportation. Next slide, please. Incubation period, I have discussed enough. It's highly variable, but commonly it is between 6 days to 6 years. Maximum documented incubation period is of 6 years. 30 to 90 days is an average, and more than 6 months of incubation period occurs in less than 1%. Bites on head and face have up to 1 month lesser incubation period, because the travel of virus to nervous tissue becomes smaller, and bite on extremities will take a longer incubation period. And that is why I said that if the virus gets into the nerve, now we have had a case where the child was mauled. Dr. Anurag also mentioned his facial nerve was already exposed. We could see his nerves. So the virus got deposited and he got treatment within an hour, but the child was not saved because the virus was deposited, and then it is a immunologically protected site. So virus is protected. You may do anything, you will not be able to catch the virus. So that is the importance. Ma'am, can we go? So lab diagnosis, we need the nervous tissue, and current diagnostic tools are not efficient to diagnose a case of rabies before the clinical disease. That is why we have to manage the animal bites, not the cases of rabies. And the classical signs of rabies are hydrophobia, aerophobia, and photophobia. And to confirm pre-mortem diagnosis becomes very, very difficult. It's a big challenge. Next slide, please. Now, role of the laboratory, of course, for diagnosis and paralytic forms of rabies becomes very important. Encephalitis and other cases. So CSF is the best sample to be sent to us, not the blood. Okay. And characterization, of course, because we want to monitor the virus as to whether it is changing or not, whether the vaccines will be effective or not. So that is more of a research that we continue, operational research that needs to be done, that the virus, and this is a very stable virus, does not change as far as we know till now. We have done so much of epidemiology, so much of molecular characterization. We see no change in the virus. And in National Action Plan for Rabies, for surveillance and disease burden, you need the lab so that we can confirm the cases. But now we encourage that all the rabies cases should be confirmed, right? And of course, now important aspect of the lab is doing the anti-rabies antibody titer estimation. Somebody asked if, we keep getting bitten, especially activists, they keep getting bitten every now and then. They getting scratched, people who look after the dogs and cats. Now, in those cases, they ask us what to do. Actually, as rightly pointed out by Dr. Agrawal, not many labs are doing anti-rabies antibody titer estimation. If your titers are above 0.5, you need not do anything. But if your titers are low, you have to take 2 doses, and 2 doses are sufficient because there will be enough generation of immune response. So now I used to work in the rabies laboratory with rabid brains. I took vaccination every year, and I've taken about 25 doses of vaccine. One dose after 3 pre-exposure doses for 21 years. I kept taking 1 dose every year, because it just gives you a boost to you. And I encouraged my staff to do it also. These vaccines, cell culture vaccines, are very, very safe. We are done away with nervous tissue vaccines where the reactions occurred. Next slide, please. Next slide, ma'am. So some of the standard test is fluorescent antibody test we do, and PCR, of course, is the test of choice these days. Next slide, ma'am. Next slide, ma'am. Sorry. So as I said, it is the previous one. Yeah. So let us treat animal bite management as medical urgency, if not emergency. Now, this is a picture of Louis Pasteur, who in 1885 vaccinated this boy, Joseph Mister, with the vaccine which he raised in the spinal cord of the rabbit. And he received multiple doses, 30 doses or something, and generated antibodies and survived. So that was the first case. So all dedication and respect for this man who contributed so much to science. Now, who should be treated? Now, this is very important question. Decision to treat is who should be treated. Now, this disease is endemic in India, I told you. So suspect all animal bites, except for 1 or 2 animals which we pointed out, and treat as per merits of the bite. Merits of the bite, meaning as per the classification. Now, people who are of old thought, people like me, old school, not thought, but old, as old and seniors, when we studied MBBS, we were taught the classification of wound as, based on site, number, and severity. If the wounds were above the waist, you considered as category class 3. If they were below the waist, it was categorized as class 1. Licks and number of wounds and site of wounds. But now this classification is not valid. And now it is classified as, ma'am, next slide, please. Next slide. So now we classify wound as category 1 is touching or feeding of animals, licks on intact skin, contact of intact skin with secretions, excretions of rabid animal or human cases. Now, in this case, you see the skin is intact, there is no chance of transmission. So it is called category 1, and you don't have to do anything except for wash the area. Then why is this category kept? This category is kept at least to tell you that such cases do not need any treatment, but you have to wash the wound and area with soap and water properly for 10 minutes. The second category is nibbling of uncovered skin. Now, if you already had a wound and if the dog has licked on that wound, because dogs and cats will lick on the raw area. So if the dog has licked, or there have been minor scratches without abrasion, like what you can see in this hand. Now, this is my hand where I got scratched with my pet dog. So I click that photo that such abrasions, they would need anti-rabies vaccines and wound management, meaning wash the area with soap and water, but they will not need immunoglobulins. Next, please. Next slide. Now, category 3, which Dr. Anurag has very clearly defined, is single or multiple transdermal bites, licks on broken skin, or contamination of mucous membrane with saliva. In these cases, you have to do wound management, rabies, give immunoglobulins, and anti-rabies vaccines. All 3. So it is a 3-pronged approach. Next slide, please. All these, whether there were scratches on the back or exposure of intact mucous membrane or big wounds. So category 1, no vaccine. Category 2, you have to manage the wound and give vaccines. Category 3, manage the wound, give vaccines and immunoglobulins, all 3. Next, please. So what are the principles of treatment? Is you have to manage the wound. I will talk about a minute I'll take on wound management. You have to give vaccination and you have to give immunoglobulins. And there was one green advice on that slide. Can I go to the previous slide? Is advice to patient. Now, it is very important to talk to the patient. I'll give you an example a little later after I do the wound management. Wound management, please. So here, next slide. Here, mechanically wash under tap water. So that is mechanical wound management. And if you don't have water, if you don't have soap, it's okay to wash the wound with soap and water, because now we understand that just plain washing will remove the, at least the virus load. At least it will wash off the saliva. And if soap is there, that helps. Antiseptics can be applied like alcohol, povidone iodine, and any household antiseptic. And biologically, what we are, that is the chemical treatment, and biologically we are infiltrating the wound with immunoglobulins or monoclonal antibodies. Suture if required, 1 or 2 loose sutures, and after administration of rig. Tetanus toxoid again is a very uniquely asked question ki ma'am tetanus dena zaruri hai kya? Now tetanus toxoid, if person has taken within last 10 days, 10 years, it's fine. They need not. But sometimes people have not taken tetanus for a long time. That is why classically it is written in the book that at least give that. But otherwise, tetanus toxoid vaccination is as per the routine immunization guidelines. And don't apply irritant, soil, chilies, oil, coffee, tea, or any tuna, or burn the wound, because it will further irritate, expose the nerve endings, and facilitate entry of virus in the nerves. Don't cauterize, don't touch. And another thing we advocate is when you're cleaning the wounds, if other person is cleaning the wounds and washing the wounds, it's better to wear gloves. Next, please. Next slide. So I will now, I think I'll stop here, because after that, Dr. Agrawal has taken it, but I will talk about advice to patient. Ma'am, meanwhile, the last slide on, thank you slide I want to talk about, so we can go to that. Now, coming to advice to the patient. Now, I'll give you just one example as to what happened with me. These people, they, develop so much of phobia about, and internet sometimes is very confusing, because there's so much of information on internet. So at times this information becomes very confusing, especially for young people. Now there was this young person who came to me with 2 of his friends, stating that ma'am, dog bite hua, and they went to a particular, ma'am, myth slide also. So that came to me and said, ma'am, dog bite one. He was very nervous. Ki I have read this on net, that on net, and he was given the correct. He was prescribed the correct treatment, and I was going for a meeting. So I told my person working with me, my technical staff, ki please explain it to him and just reassure him that nothing will happen. I've seen treatment is fine. So she told him, you have taken the immunoglobulins. You've started with your vaccination. Please continue the schedule. Don't worry, everything is fine. And she said, okay. And then he was still nervous. Ma'am, is it okay? Is it complete? So he said, okay, you observe the dog also for 10 days. That is a dog near your house. Just observe the dog for 10 days. And if dog is okay, you need not worry at all. Then the dog does not have rabies. You will also not, you will not get rabies at all. And I was just listening, collecting my papers, and I left for the meeting. 3 days later, this person was brought by 2 of his friends. He was dragged to my office, and I was so scared, because he couldn't walk. His eyes were all rolling up. And I was wondering what is happening. So I asked him, I said, what happened? He said, madam, I cannot watch the dog anymore. So what he had understood of our communication is what he did was tied the dog on the cot, and he kept looking at the dog like this, because we told him that watch the dog for 10 days. You see, this is how we doctors talk. And I was so ashamed of myself, that I was standing there when she said, tum kutte ko dekh lena. 10 din, kutte ko kuch nahi hoga, to tumhe bhi kuch nahi hoga. So he tied the dog, and his friends told me, even while he was going to the toilet, he was watching the dog like this. So that is how we communicate with our patient. Why I give this example is that we have to be very careful when we communicate with the patient. It is an art. So talking to the patient, giving them the right advice in the right words. Now, this is what I call communication, because what you're saying is something else. What other person is perceiving is totally different. So you have to come at that level with the patients, explain to them what you're saying and why you're saying. And so to allay their fears. That is our responsibility. So certain myths and rabies, like herbal medicine, concoction, beetle leaves, etc., will cure, or chilies, mustard oil, all these are myths. Gemstones, washing the wound with water will cause hydrophobia. Now, this was another person another doctor who told a patient कि बहुत ज़्यादा पानी के पास जाओगे तो हाइड्रोफोबिया हो जाएगा, फिर तो तुम्हें ये बीमारी लग जाएगी. So these are all myths. Never say that. No diet will influence. So this vaccination does not need anything, no restriction of diet. People will ask you, okay, should we stop eating non-vegetarian food? Nothing, no restriction is required. Only alcohol consumption should be decreased. They should not consume alcohol a lot. And physical activity, like any other vaccination, should be decreasing to a low level till the time vaccine schedule is complete. So, taking bath, etc., does not provoke any hydrophobia. So these are some of the myths, some of the questions that you will need to answer while you are dealing with cases. So I thought we can discuss these also. Next slide, please. So key points have been already put up by Dr. Anurag Agarwal, that all warm-blooded animals can transmit the disease. So you have to suspect all animals and treat it judiciously, effectively as per the guidelines, national guidelines. Next slide, please. Give immunoglobulins and vaccination and wound management. With all three are equal. They are like fork. All three are very, very important, like a tripod stand. Next slide, please. So these are some of the key points. All cell culture vaccines are effective. And next press also, ma'am. So I want to dedicate this talk to my mentors. I have been mentored by some very, very people who are stalwarts in the field, Dr. R.L.H. Pujani, Dr. Rajesh Bhatia. I dedicate this talk to all juniors and seniors who encouraged me, who made me learn. I dedicate this talks to my students and my PhD students who made me learn so much by asking questions. People like Dr. Anurag Agrawal, who never forget to invite me in any of the Rabies forum. And by answering all these questions, one learns, and we don't answer questions, we go and seek answers for these questions. And to all my animal bite victims who still call me and ask me questions and want reassurance. So with those words, I thank you all for very, very patient listening. Namaskar. Any questions, I'll take it. Thank you, ma'am. Thank you so much for helping.
Thank you, Dr. Mala Chabra. Even so many of my doubts were cleared, because when I write standard treatment guideline and update according to the national guideline, some of it I did not understand, but I did, aligned it with the national guidelines. But now I know the rationale behind it. I think there are two things I think which would need, there were questions in the chat box. One is, reactions with ARV, and second is, what if some doses of ARV are missed?
Very
if the
good.
patient is, these are the two things. I think if you cover that would be good.
Excellent questions, ma'am. First was, what do I answer first? Which one?
Anyone, reactions to ARV and missed doses.
Okay. So reactions to ARV. I want to assure you that I have been working in this field for the last 23 years. I have just seen 2 reactions to ARV. That also we do not know whether they were actually react, because there's no way to prove it. These vaccines are absolutely safe. Especially when we were talking about reactions to ARV, that was when we were using nervous tissue vaccines, which were given in the abdominal wall. 10 to 12 doses were given. Those vaccines, because they were made in the nerve, spinal cord of the animals, sheep. So that is why they cause some reactions. But all the vaccines that were shown by Dr. Anurag Agarwal, I can name a few: Rabipur, Virorab, Abhairab. All these vaccines are killed vaccines, and the virus has been cultured in cell lines. It could be human diploid cell lines, it could be viro cell lines, and all. So what you get is only the virus and killing and some preservative. That is what the vaccines are. So these vaccines are very safe. So even in transplant patients, even in other immunocompromised patients, HIV patients, everybody's got these vaccines. And I think we should not be talking about any side effects of these vaccines, because they are.
Someone mentioned fever, if there is fever with the ARV.
Yes, ma'am. Now, usually fever will not come because of ARV. Usually, It can happen because of it's an inflammatory response, but usually the fever is because of injection of immunoglobulin. So they get 1 or 2 days of fever and redness around the site because that is something a biological product. So one can get fever, but nothing to worry. Plain paracetamol helps in these cases. And there will be redness around the wound. And sometimes when we are giving intradermal vaccination, because of the blood, there will be some redness and irritation, which is all acceptable. So there's nothing to worry about these two things. Now coming to missed doses, that's what was asked, right? Now again, as I said, so we give 0, 3, 7, 14 and 28 if we are giving intramuscular schedule 5 doses. Now please remember, the first 3 doses should be given within 7 days. First 3 doses should be given within 7 days. They almost constitute like primary vaccination. So suppose one was given today and a third day the OPD is closed or you cannot take it on fourth day. And then 7th day vaccination should be on the same day. Or if 1 or 2 days here and there, it does not matter. But try and cover. Why this becomes important is because of generation of immune response. So first 3 doses become important. Next 2 doses on 14th and 28th day can be given within a week of that time, that bracket of that time. So if we do that, now this is a general guidelines we give to a people who are managing the anti-rabies clinics, because they should broadly have an idea as to what is the mechanism of generation of antibodies when we give this vaccination. I think that broadly covers. Now when we are talking about intradermal, same thing, we are not giving 14th day. So first 3 doses within 7, try and give within 7 days. So 2 sites on day 0, 2 sites on day 3rd and 7th, and then 28th. Now again, there will be another question which I want to preempt is, usually we give it on the deltoids. Now sometimes in our OPDs it's not possible. If person, you can give it another site is anterolateral aspect of the thigh. Now I was asked a question that the army officer has lost both his arms. Ab kahan de? So why we are giving intradermal vaccines on deltoid or anterolateral? No, there is a broader guideline. There is a logic behind it, is that you are targeting now. Many time people ask कि intradermal में तो आपने 0.1 दिया, very small amount, whereas intramuscular is 0.5 or 1 ml. Now, how will the immune response be generated? What is the difference? So the difference is that when you are giving intradermal, it is not going in blood. It is taken up by lymphatic system and it is going to antigen presenting cells. So immune response is huge immune response is generated. When we give IM, it goes into blood and it's circulated. So it gets diluted in 5 liters of blood and it gets circulated, and the antigen generating cells are stimulated. Now with the same principle, so see whether it is, and we are targeting the pockets of the lymph node. So if pockets of the lymph node arms are not available, then we can target other pocket. You could give it on the shoulders or below the scapula. So you have to see where are the lymph nodes. So, and give it intradermally. Now again, intradermal, that beautiful bleb he was showing, is very important that it does not go subcutaneous, because of this very reason, that you want the lymphatics to take them up, not the blood. So that is the idea. So have I answered both the questions?
Yeah, I think that that was a very good explanation. Riga, I am seeing some questions in the chat, but they are all around. Suppose they did not come on that particular day. The idea behind is resume, stick to the regime as far as possible. If missed for some various reasons, resume it as early as possible. I think that's the only idea.
And another thing that question will come is 3 doses to le liye, then they've gone away somewhere and things like that. So if the gap increases, it's fine, because primary is important, then 2 as soon as possible within the gap of 14 days to generate the immune response.
I think one query which still is in there in my mind is the dog has bitten through the clothing. There is no clothing is intact, but there is when you look below the clothing, there is a teeth mark or bruise is there. Would this which category does this wound belong?
So ma'am, if there is bruise and teeth mark, we will put it in category 2. as minor abrasions and wash the wound with soap and wash the area with soap and water properly, so that, because even if the clothes are intact and if there is bruise and teeth have touched the skin, which means the saliva may have touched, so manage the wound with soap and water and give vaccination. No need of immunoglobulins.
Okay.
So that will be taken as category 2. Another golden rule that I always tell is for rabies is that if you have to make a mistake, if you have to err it on the right side. So because these vaccines are absolutely safe, and we are trying to promote now, IAP is trying to promote pre-exposure vaccination. Government of India did not take it up till now because there was shortage of for post exposure, shortage of vaccines for post exposure. But after intradermal, that shortage has been taken care of. So now we might think of advocating. IAP always says that even now they have in their guidelines that take pre-exposure prophylaxis, whoever can afford it. But Government of India cannot say that, that take pre-exposure, whoever can afford it. It has to be for everyone if we come for it, right? So that is why if you make an error on the right side, complete 3 doses at least, you make it a pre-exposure prophylaxis, so that further if you get exposed, in our country one can, then your you don't need immunoglobulins and only 2 doses of vaccination.
Okay, there is, just preempted this question. There is a dog in my colony who is biting, everyone. And this has been there for almost a year or, 6 months. He's been doing it. Now clearly this dog is not rabid, but he has got the habit of biting, and he bites very badly also. So what should the people do, about this time? What they need.
Thought that I should say, ma'am, बस अब हो गया, अब और नहीं आंसर करूंगी. No, such case.
नहीं, मैं दिस इज ए प्रैक्टिकल प्रॉब्लम. वो रोज काटता है और बच्चों को काटता है. ही सिट्स आउटसाइड द स्कूल एंड बच्चों को पीछे से टांग पकड़ के काट लेता है एंड दे ब्लीड बैडली. एंड सडनली वो, क्योंकि 6 महीने से तो जिंदा मैं ही देख रही हूँ उसको, तो वो रैबिट तो नहीं है वो.
Rabbit nahi hai. Some dogs have habit of biting it, and that is why we are very closely working with the veterinary colleagues now that such dogs should be vaccinated every time, and if possible they should be relocated in the dog ponds, which is again very difficult because there will be animal activists. Let's not enter that field, but I also want to thank the veterinary colleagues who listen to us so much, and now they are working on animal dog vaccinations. Yeah, so such dogs need to be vaccinated or shifted to other place because
अब जिनको जो विक्टिम्स हैं, उनको तो पूरा वैक्सीनेशन और आईजी वगैरह सब लेना पड़ेगा ना.
Yes, ma'am. इसीलिए we are trying to tell them that once a while dogs they are naughty, sometimes, and they by habit they bite. So such animals should be shifted to either dog ponds or should be at least vaccinated annually. At least, because you will never know when they get rabid. Suppose they are bitten by a rabid dog, you will think that okay, this dog is always biting, so no worries. So there should never be that complacency. If the dog is bitten, the person should take post-exposure prophylaxis.
Thank you, ma'am, so much. I think today was a special day, and I think dog bite is such a prevalent this thing, all these aspects of wound management, vaccination, and do's and don'ts are all important. But we have short time. Session is from 3 to 5, and already. It's already 5 o'clock. What do we do, Dr. Srivastav? I think I don't know whether the participants would like to stay on. We haven't done quiz, and I haven't done my session today. What do we do? सर आप म्यूट पे हैं सर. सर आप म्यूट. You are muted. We can't hear you.
Meanwhile, you can share my number or mail, or I'll give you the correct presentation that I made for this particular thing.
Yeah.
That you can share.
For the participants, this YouTube recording will be available. so they can go through the presentation. If they have missed anything, they can go through again. By next week, I think Annapurna is able to do that, so you will get a YouTube link for the today's session also. Sir, we have Dr. Arvind Mohan also here. I don't know, the time is the limit today. He is also looking after the dog bite clinic at LNJP hospital. I think Dr. Arvind Mohan, we have covered all the aspects. If there is anything, 1 or 2 points that we haven't touched, maybe you can come in and share with the participants here.
No, ma'am, most of the things have already been covered by both the speakers. So nothing more to say here now.
Okay. Any advice you would like to give for those who are managing clinics in the hospitals, dog bite clinics? Anything that they are specifically need to, besides the management of this thing, running of the clinics?
The first and foremost is years back, we had an acute shortage of vaccine in Delhi as well as in NCR area. Due to some policy decision by central government, most of the manufacturers were more interested in exporting the vaccines to outside rather than for domestic use. So at that time we had an acute shortage of vaccines on all over Delhi. And luckily, our hospital LNJP was having enough buffer stock with us. And once that was consumed, we later on went for local purchase of the vaccine. So somehow we managed the show for almost 6 months, and we were receiving at the time around 600 to 700 patients per day. So my suggestion is that everybody should have a adequate amount of buffer stock of vaccines so that there is no shortage. Otherwise, patient has to roam around in search of these vaccine, which is very important within, 14 days.
Doctor, can you also, explain about the storage of these vaccine? I think that's very important. The vaccine on which we are depending needs to be potent when we are giving. So any storage instructions you would like to give to the group here today?
In our hospital, we have got 2 storage facilities. First is a central drug store, which has storage facilities for a huge amount of drugs. As we know, LNJP hospital is quite a big hospital. And the second storage facility we have are at anti-rabies clinic. So we have a buffer stock of around 1 month, and the central drug store has the storage of around 6 months of this drugs. So we can go for we can use both the facilities fully for efficient management and the storage of these vaccines.
My point was, Dr. Arvind, at what temperature should it be used? And suppose you open a vial, how much time is there to utilize that vial?
We have to keep the vaccine between 2 to 8 degrees centigrade of temperature. Once we are planning to inoculate these vaccines into patient, we have to bring it to a temperature of around 25 to 30 degrees centigrade before inoculating. So as far as the storage is concerned, it should be between 2 to 8 degrees centigrade, but before around 25 to 30 degrees centigrade.
For how long can you keep the open vials? 6 to 8 hours, or how many?
As soon as possible is the.
What is the maximum time that the open vial can be used?
We keep it for 2 or 3 hours maximum, and after that we prefer to discard it.
I'm 6 hours now because that is for convenience. So because usually the working hours will be 6 hours, so we always tell the people that before leaving your own duty you should discard that vaccine. So 6 hours can be done as per the national guidelines.
Okay, discard, you use the word, how do you discard the remaining vaccine in the vial?
Send it for incineration, ma'am.
Okay, yellow bag. Yellow bag is the, you have to, but this needs pre-treatment?
No, because it's a killed vaccine, nothing is to be done.
Okay. So these vials, the glassware will go, how do you, discard this? Uh, vaccine would be there and there would be a glass. Hello? Hello? Hello, I think there is some issue with the connectivity. Sir, what do we do? Today we have crossed the time limit. Hello, sir, we can't hear you. Yes, yeah.
Hey, am I audible now?
Yes, sir, yes, sir.
I mean, I would feel that since today is Shivratri, so you can just go through the quiz.
Okay.
Because from public health point of view, the audiences are common. Perhaps when we meet next month,
Yes.
the remaining points will be covered, and then it's already
Yeah.
around 5 o'clock. But anyway, I mean, I don't know whether I am audible to Dr. Mala Chabla or not. It was extremely, in fact, useful information from our perspective when we work with the district hospital and lower down. And
Thank you,
really
sir.
appreciate your time and indulgence on this topic. And you have really solved a lot of many common concerns, which as a clinician, as a practitioner, is still very, I mean, we don't recall or don't remember, and a lot of misgivings sets in over period of time. Thank you so much.
Thank you, sir. Thank you. Available anytime, sir. No problems if you have to contribute anywhere. Thank you so much.
Thank you, ma'am. Okay, I quickly go through the pre-test quiz questions. Can you see my screen? Okay, I'll just quickly go through the questions. Demography, I think, remains the same. Our group mostly is from the government sector, mostly doctors, but there have been, from all levels of healthcare, first question, because I was to, take the high alert medication handling. So, I just, had put a question on this. What classifies as a drug, as a high alert medication? What do you mean by high alert medicines? These are usually drugs which have a narrow therapeutic index, because the difference between the safe dose and the dose which is toxic is very small. So if you give a dose in error, these patients can land in toxicity. But if you are on the underdose side, these patients, the whatever indication that you gave in, they may not respond, so they may relapse. If it is seizures, anti-epileptic drug, they may have a breakthrough seizure. If it is insulin, they will have a underdose, will have hyperglycemia. But if you give a higher dose of insulin, devastating effect would be there. So usually these are not the bad drugs. They are very good therapeutically, they have a very good effect. But when given in error, the outcome is devastating. The error is so grave, it may be life threatening for the patient. Simple example here is insulin is a very good drug to lower euglycemia. But when you give it in a dose by mistake, higher dose by mistake, it can lead to hypoglycemia, which can be life threatening. So high alert medications are those with a narrow therapeutic, and the when given in error, outcome is devastating. Look alike, sound alike, some people say that they are also high alert, but the as the name suggests, high alert is a very a small list of drugs for which the facility, each one, the healthcare worker who are dealing with the doctors, nurses, and the pharmacists, they know about that this is a high alert drug, so that there is no dosage error, there is no patient error, route is correct, and all that. But if you make this, because there may be many look-alike drugs which they are there in your health facility, but if you add them up all, it may run into 100 or 150 drug list, that will defeat the purpose. So these are a select group of medicines for which each one should know the maximum dose, what to do if overdose happens, how to treat the patient, like that. So that is the objective of identifying the high alert medicines. Now there is another question, which of the following can be crushed and given via nasogastric tube? Often we have unconscious patients with us, or those who cannot take orally. We put them on nasogastric tube. The general notion is that people think that they can crush anything and mix it with the food and give it to the patient, but there are certain dosage forms which cannot be crushed and given by nasogastric tube, because they have been designed in a way for delivery of the drug in the body. So for example, enteric coated tablets and the sustained release tablets, or time release, long acting, extended release, these kind of tablets are very much available. Controlled release, they have been these modified release tablets have been designed in a manner that they release the drug slowly in the body, to cover up for the time. But if you crush them, all of it will be delivered at once, and it can lead to toxicity. One good example is nifedipine. If you are using a nifedipine controlled release preparation, the idea is to control hypertension in a control, have a modified release over a time. But if you crush it, all of it will be released, and the patient they may die of hypotension. So be careful, which tablets can be crushed and which cannot be crushed. Similarly, enteric coated tablets, these also need not be crushed, because they have been designed to be released in the body once they leave the stomach. So but if you crush it, the whole of it, the drug component, will be delivered in the stomach and will be absorbed. So these two categories cannot be crushed and given. Many a times, the depending on the drug, the cardiac arrest which happens in the health facility is because of this a very innocent mistake that may happen in the wards. So that's what I wanted to tell you here. The message was here. Now then, how do you write the prescription? Use of decimals. When will you use the decimal, and when will you use the zero, trailing, or naked zero, like that? So which of this is the safest and most appropriate way to represent a number in the prescription? We write 0.5 like this. This is very, this is error prone way of writing a dose here. As far as possible, when we are writing prescription, we should avoid using a use of decimal here. If it is inevitable, certain doses, drugs have to be given in microgram doses. For example, thyroxine, very often we give this thyroxine 125 micrograms is required. So it is, instead of writing 0.125 milligram of thyroxine, we should write 125 micrograms, because we know how the patients are keeping their prescriptions. If they get mutilated, water dropped on it, this decimal may not be very much visible. So this patient may get 10 times the higher dose. Instead of 0.5, we may get the 5 milligram dose. Similarly, writing a zero after a whole number is also not needed, again, because if this decimal gets disappear, again the patient may get 10 times the higher dose. So right way of writing is 0.5. So you should put zero when it comes before the number, but after is not needed. Then sorry. Then multi-dose vials, how do you use them? For how long can you after opening, for how long should you be keeping? How do you maintain that vial? Very often we've seen that multi-dose vials are opened, but we don't know for how long they can be used, because there is a shelf life after opening. There are two expiries here. One is the one written on the vial by the manufacturer. You can use up to that date, but once you open, even before that expiry, if you open, it doesn't mean that you can use this vial indefinitely. So it is, but very often, because there is nothing written on, no date is mentioned, so we don't know. Some drugs have preservatives, so they can be used for a longer time. Some vials do not have preservative, so they have to be used within the same day. So we have to look at the manufacturer's instruction in these cases. Usually multi-dose vials can be used up to 28 days, but then when was this opened, we don't know. So always it is better that we need to discard this after 28 days, but this you will know only when we have mentioned the date of opening on the vial and with your initials, who did it. I would go further, instead of putting the date of opening of the vial, I would rather you write a beyond use date here. I would calculate, factor in this 28 days or 1 days, whatever is the manufacturer's requirement here, and then write the beyond use date, so that anyone who picks up this multi-dose vial knows that he cannot use this vial beyond this date. So it needs to be discarded after 28 days. Do we have Dr. Punangjun? Are you there? I will, let's see if she is there. I'll go to the other question and then come back when she comes online. Following are the red flag signs in a child. I think most of you have answered this correctly, but I'm burning pain. Red flag signs means that the child has to be seen on priority in emergency department. So you cannot afford to have a delay here seeing the child. But these two, burning pain during micturition, that indicates that there may be some urine infection, or passing loose stools frequently, although the mother may be very much disturbed, but this does not per se is a red flag sign. But what you need to look at is whether there has been dehydration or not. So these children can be seen in an outpatient department, but all other patients with difficulty breathing, more than 40-degree temperature, fever present for more than 24 hours and returning, the child is crying inconsolably, or there are purple or red spots on the skin, meningitis, things like that could be there, or drooling of saliva and inability to swallow. All these are red flag signs. These children should be seen in emergency. Now here is a case, there is a question about An 83-year-old woman is admitted to emergency having noted to be increasingly confused and aggressive. She's suffering from type 2 diabetes, epilepsy, osteoarthritis. Her regular medications are metformin, aspirin, ibuprofen, omeprazole, ramipril, temazepam, phenytoin. Which one of these is contributing to her confusion and aggression? Only 50% of you have correctly answered temazepam. These benzodiazepines are often used by these elderly because they have difficulties falling asleep or maintaining sleep. So very often they are put on these benzodiazepine, but these can give rise to confusion and aggression. So whenever you see an elderly patient, please go through their medication history, and if you find any one of these, then you know what is the cause of his confusion and aggression. I think the last two questions were on dog bite. These questions were adequately answered by the experts today with us. So dog bite post exposure treatment with anti-rabies vaccine against rabies is recommended in, I think teeth mark, bruises, nibbling of the abrasions, licks on the broken skin, but touching and licking on intact skin does not warrant vaccination, post-exposure vaccination. And I still, about 38% said any bite irrespective of the wound category. This is not true. In the idea now, I think three categories have been defined that decide the mode of treatment. So there is no need of post exposure treatment if dog is vaccinated, if you know, yes, if you know that the vaccination. But the pitfalls of vaccination history or the quality of vaccination, I think Dr. Mala Chabra touched on this, that itself will, you cannot only rely on this part for the management of rabies. Then the second question was about 5-year-old boy who had been scratched by a stray dog 15 days ago. When he went for a job interview, there was a minor ooze of blood. He washed it with water immediately. His friend now advised him to visit a doctor. How would you manage him? I think Dr. Mala Chhabra, explained this in a beautiful manner, because there is a variable incubation period, and because of this variation incubation period, we may not lose this opportunity of vaccinating. So still, immunoglobulin and anti-rabies, because this is a category 3 vaccination wound, so both these would be required. Reassurance, and I think it is quite clear it would need both IG and vaccination. And ask him to trace the dog, and management will be as per the status of the dog. This is a very difficult task. If it is a pet animal, yes, you can do it, but if it is a wild stray dog or stray cat, you may not be able to trace the animal. So and she said to err on the safer side. So give both vaccination and the immunoglobulins. I think with this, and Dr. Poonam, are you there?
Yes, ma'am, I'm there.
Yeah.
Hello, ma'am.
Okay. This is the
Yeah.
question on doctor. Let me just introduce her. She's a obs and gynecologist specialist. She's working in Delhi at Sanjay Gandhi Hospital. I think for this, I had included this magnesium sulfate as a high alert drug for the today's session. So I think she would be the best person to answer this question. Please, Dr. Poonam.
Yeah, thank you, ma'am. Ma'am, Pritchard regime is the most commonly used regime in the treatment as well as prophylaxis of eclampsia. So it is rightly given, the answers have rightly been given. It is given as a 4-gram loading dose IV 20% and given over a time of 5 to 10 minutes, and it is followed by 5-gram IM in each buttock. That makes it 4 plus 5 and 5, that is 14 gram is the dose that is given. This is absolutely correct. Recurrent fit, if the patient still has, even after giving a loading dose and an IM dose, then you repeat 2 to 4 gram again in a duration of 5 minutes. 20% is the dilution we make it. This is also given correctly by 26% people. In case they do not have Mexel should be the first choice. In case they do not have, depending upon the setting, that other drugs that can be given are diazepam, phenytoin, but preferably it should be Mexel only, but it depends upon the setting. And then, of course, Mexel, it has to be given only 24 hours post delivery or post fit, whichever is later. It has to be given, and this Pritchard regime is given after the loading dose, 4 hourly, on alternate buttocks as an IM dose, depending on what are the deep tendon reflexes are present or not, the urinary output and the respiratory rate. And it is not to be given for a very long time, of course, 24 hours is the limit. So it causes, the last choice tells us that it can cause side effects. So that's it, ma'am. If somebody has any query regarding
if
it.
you can elaborate on the side effects of the hypermagnesemia and how to handle that.
Ma'am, the therapeutic range is around 4 to 7. The issue comes, it's relatively safer, I would say, in the sense that the moment we have to repeat those in Pritchard regime, we have to repeat it every 4 hourly. So we are monitoring three things basically. One is the deep tendon reflex, one is the respiratory rate, one is the output. So the deep tendon reflexes are the first to go away whenever there is a little higher dose of Mexel in the body. So once this is there, we omit the next dose. We do not give, we wait again 4 hours, and after 4 hours, we again see the three parameters. If the output is more than 30 ml in an hour, if the deep tendon reflexes are present, or if the respiratory rate is more than 16, we can give the next dose. So it is given in a way that all these three parameters are there, then only we give the next dose. So the side effects are also the same way. Since the reflexes are absent, patient will be drowsy, sluggish, and then the output will decrease, and patient, these nausea and these kind of side effects the patient will have. But still, if we continue to give irrespective of the side effects, then patient will ultimately, after a respiratory, she'll have a little arrest, and finally she'll have a cardiac arrest. So these are, because it's a neuromuscular relaxant, it's a membrane stabilizer otherwise, but here it causes all sluggish, all the neuromuscular relaxant. So patient becomes very sluggish. That is one of the most common side effects.
Thank you, Dr. Poonam. I think with this, I can stop here. We can close today's session. I think please don't attempt pre-test now because it's already over. I will turn off.
Even we are not sharing, ma'am, because it is already.
No, they are doing it. I can see that, while I was, presenting the results of the quiz, I saw a few people attempting to do pre-test also. Please attempt the post-test. I know most of it, some of it, I think was covered now. And in the answers in the discussion today, but try to finish this because certificate is linked with those who complete the post test. So please do that. Otherwise, you will keep asking for the certificate and you will not get it. Post test link and feedback form link is there. I think yes, you can finish this. Thank you, Dr. Poonam, Dr. Mala, and Dr. Arvind, Dr. Anurag, for coming up today, sparing time and discussing the management of dog bite with the participants.
Thank you, ma'am. Thank you on behalf of NHSRC. I thank to Dr. Sangeeta Sharma, Dr. Mala Chabra, and also Dr. Anurag Agarwal. And I also thank our Dr. Jain Srivatsav sir, advisor QPS team. Thank you for all the participants for making this successful sessions. And our next session is again on 18th of March on the foreign bodies. Please attend the next session also. We will share the link to your mails. And who has attended pre and post test, you will get the certificates by after 3 to 4 days. The session related with the dog bite, we have our YouTube channel in the name of Quality and Patient Safety. Please, we have shared the link in the chat box also. So please go access through that, and you can get the YouTube. And for this session and all the previous sessions, YouTube's you can observe through or you can watch through the YouTube channel. Thank you all, ma'am. Thank you, all the participants.
Please complete the post test and feedback. I see 110 around that people have.
YouTube link also shared in the chat box. You can access through that.
Okay. You have the link, Annapurna. Do I need to send you again for this thing?
For which one, ma'am?
For both pre and post?
I
Do
have,
you
ma'am.
want-
I have.
You can access these responses, no?
Yes, ma'am. Yes, ma'am. Thank
I
you.
need not send you again, no? Okay.
No, ma'am. No, ma'am.
Okay. Once again, thank you to all of you for sparing time on this Saturday afternoon. That shows your commitment as well, that you take out time these sessions.
Thank you all. We are ending the session now.
I think they have opened the link and they have no problem. They can complete it and submit it, so it will not affect. We can end the session.
Thank you, ma'am. Thank you all. इधर देखो